Okay, diffuse. I was like, what? Hello, hello, hello. We are live. Hello, everyone. I am so happy to be here. I think I might be frozen, and I am so sorry. Hi, Alexis.
Hello, how are you, Dr. Bailey?
I'm doing great. And I think I might be frozen, Joy, so I'll probably bounce out and let Alexis go from here. But hi, Alexis. It's so good to have you back on the stage with us.
I know it's been a few it's been a few years.
It has. So I'm going to hand it on over to you to go through our disclaimer. And if you would go ahead and introduce, or not introduce, everyone knows Dr. Sharma. Dr. Sharma, we're so grateful that you have been willing to come on and do this. And this is the third session, and it's been fantastic. So we won't have to introduce you, but I'm going to hand it all over to Alexis. Thank you so much, everyone, for joining us. And as a reminder, I will be with you next Thursday to wrap this up. And then our final sessions will occur at the Warriors Convention. Take it away, Alexis.
Okay, thank you. All right, everybody. I hope everybody is doing well, that you have your water, that you are taking your meds, that you're resting, and that you're ready for another session. Let's go ahead and get our disclaimer read out the way just to make sure that everyone understands that, where we are with the class. Okay, before we begin, the patients, caregivers, and community-based organizations of the Sickle Cell Consortium are delighted to provide Warrior University as an online curriculum-based education module. However, please note this is a general discussion and is not meant to replace the advice or instructions of your doctor or other healthcare professional. Statements made are not meant to reflect the policies, thoughts, or opinions of the consortium and do not imply endorsement or recruitment for any product, service, or clinical trial. As a reminder, this class is recorded and will be made publicly available online. Private questions should be addressed to me, listed possibly as either Lakia Bailey on the screen or as Alexis Wardlow, or you can send them directly to the presenter. Alrighty.
All right. So I'll take it away from here. Hi, everyone. I think we've been here at least 2 times before. And so I think all of you know me already. I'm going to start sharing my screen. There we go. And okay, here we are. So can somebody confirm that you can see my screen and hear me? Alexis, Sharonda? Okay, I'm not hearing anyone. Just making sure that somebody is able to hear me.
Yes, sir, we can.
Okay, perfect. Great. Fantastic. And you can see my screen as well, right?
Yes, sir.
Okay, fantastic. Okay, so hi everyone. This is the third class in the series of potentially curative therapies for sickle cell disease, and today we'll be talking about gene editing. So the first class we talked about transplantation, where we take cells from one person and put them in another person. The second class we talked about gene therapy, which uses a lentiviral vector where we add a gene. So now today we are talking about modifying genes. But before we go into that, I do want to share some conflicts of interest and disclosures. So as I've mentioned previously, I consult for a couple of companies that are developing gene therapy products for patients with sickle cell disease. And I'm also the clinical trial site PI at St. Jude for a number of these clinical trials as well. So as a part of that job, my institution receives funding from these companies. Um, but I'm not gonna talk about any one particular therapy today. I'm gonna give you the clinical trial results of all the therapies that have been declared so far. And so I'll give you all that in that manner, but just keep this in mind. And like it was said previously by Alexis, the information that I'm providing in this talk is for general education only. I'm a medical provider, but I'm not your medical provider. So if you want specific medical advice, I would recommend that you go to your doctor and ask them questions about your health. But if there are general questions about what we are discussing today, I will be more than happy to answer them. So the objectives of today's class will be to discuss different gene editing based approaches to treat sickle cell disease. And then we will briefly discuss the relative risks and the benefits of one approach over another. And so, before I get started about gene editing, I want to talk about some general concepts in sickle cell disease. I think many of you probably know that already. But if you have a large amount of sickle hemoglobin and small amount of fetal hemoglobin, people have more pain episodes, more acute chest, they have a poor quality of life, and it all leads to a shortened lifespan. Now, if somehow we could increase the amount of fetal hemoglobin and reduce sickle hemoglobin, that reduces pain crisis, that reduces acute chest, improves quality of life, and increases lifespan. Now, this is what hydroxyurea does. Hydroxyurea increases fetal hemoglobin in your red blood cells. But the problem with hydroxyurea is that, first of all, it has to be taken on a daily basis. You have to take it every single day. If you don't take it regularly, it's not going to work. And then, even if some people take it regularly every single day, it may not work in every single person. So to address these problems, we have been thinking for a very long time, how can we increase fetal hemoglobin permanently and by one type therapy? So that's where gene therapy comes into being. So last week we talked about gene replacement or gene addition, where you add a normal copy of the gene to the cells. Today, we will talk about different methods of gene editing to increase fetal hemoglobin. Okay. So, very briefly, I want to talk about what causes sickle cell disease. We've talked about this in previous classes as well. So, we mentioned that sickle cell disease is caused due to a mutation in the beta globin gene, where instead of glutamic acid, the globin molecule has valine. And normally, hemoglobin molecules should look like this. They should be separate, individual, separated from each other. But when you have sickle cell disease, under hypoxic conditions, under low oxygen, these molecules, they form long chains called polymers, and these polymers are responsible for the sickled shape of the red blood cell. And so, what if we could somehow turn the sickle hemoglobin back to fetal hemoglobin? And so, how do you do that? So, what happens around the time of birth is another protein called BCL11A, it gets produced, and BCL11A, it binds to the globin genes, the fetal globin genes here, and it stops them from functioning and turns on the beta globin gene, which has the sickle mutation. So I'm just showing that all over again so that everybody is on the same page. So here is a cell, and in that cell you have these three things, genes. Okay, one of them is called BCL11A. Think of this BCL11A as the master switch. Okay, what this master switch does is it inactivates or stops fetal hemoglobin, and it turns on the beta globin, which has the sickle mutation. So it turns on sickle globin. And if you could somehow get rid of that master switch, fetal hemoglobin will turn on and sickle hemoglobin will go down. So let's see how we do that. So this is what is happening in the mother's womb. When we are a baby, when we are all in our mother's womb, we are making fetal hemoglobin, because at that time this master switch is off, and around the time of birth the master switch gets turned on. It turns off fetal hemoglobin, turns on sickle hemoglobin, and we see sickle cells. So I'll show you this thing once again. Here it is off. So when this master switch BCL11A is off, you are making fetal hemoglobin and you have normal red blood cells. Now see what happens? When we turn on the master switch, fetal hemoglobin gets turned off, sickle hemoglobin gets turned on, and we make sickle cells. All right? Now, if we can somehow block or suppress BCL11A, we will get back to the fetal stage where we make fetal hemoglobin, which leads to normal blood cells and less sickle hemoglobin. So this is the whole point of trying to do gene therapy or gene editing. So, as I mentioned earlier, this gene, BCL11A, the master switch, it turns off the fetal genes and turns on the adult sickle gene. If we use a molecular scissor called Cas9, it's a scissor which goes and cuts the genes where we want them to be cut. So if we take a scissor and cut the BCL11A gene, the BCL11A gene won't be there anymore, and fetal hemoglobin will get turned on again. So that's one way to do that. Another way is we take our RNA, and instead of doing anything to the gene, we take this RNA and suppress the RNA which is being produced from BCL11A. Again, we get rid of the BCL11A and fetal hemoglobin gets turned on. And the third approach is we take that same scissor, and instead of cutting at BCL11A gene, we cut where BCL11A binds. Now, BCL11A cannot bind the fetal genes, and it turns the fetal genes on again. So there are three different ways in which we can use gene therapy, gene editing to produce more fetal hemoglobin. And by doing that, we can increase the amount of fetal hemoglobin in the red blood cells. So again, this is very hi-fi and complicated. I'm going to simplify it a little bit because I'm a simple guy. That's how I understand. So remember, we talked about spelling mistakes previously. Like a sickle mutation is like a spelling mistake. So here you can see these are the spelling mistakes. Now, what these scissors do is they go and cut where we want them to cut. Sometimes it may be where the spelling mistake is. Sometimes we may want them to cut somewhere else. And when these scissors cut there, they introduce just random alphabets in place of the spelling mistake. And so by doing this, we can break the switch. So if we cut at BC11A, we can break that switch and turn that off, or we can cut where BC11A binds and break that switch that way. Now, some of you would be thinking, well, Dr. Sharma, you were saying this is going to be gene editing. This does not look like editing. This looks more like gene vandalism. And you would be right. We are introducing random words, random alphabets, but at the right site. By doing that, we can break the switch, and that works just as well for us. And so this is what gene editing looks like. And so how do we do this? Here is a sickle cell disease patient, and on the right side, this is what their blood looks like. They have a lot of sickle cells. So the first thing you do is you collect their cells. Once you have collected these cells, you grow them in the laboratory, and then you either take the shRNA or the CRISPR-Cas9 enzyme, you edit the stem cells, then you still have to give chemotherapy to the patient to get rid of the stem cells which produce sickle cells. Their bone marrow then gets empty, and now you put these edited stem cells which have been edited using CRISPR-Cas9 back into this patient, and now these cells make a lot of fetal hemoglobin that does not allow these cells to sickle, and now the patient has normal blood cells and they don't have sickle cell disease anymore. So this approach of doing gene therapy, it is in clinical trials right now, and I'm going to talk about a couple of different trials that are ongoing, and I'm going to show you their data. So I told you there are three ways to do gene therapy to increase fetal hemoglobin. Okay, I'm going to talk about approach number one first. So approach number one was editing at the BCL11A gene itself. Okay, now there is a company called CRISPR Therapeutics and Vertex Pharmaceuticals. These two companies, they got together and they're conducting this study. They have treated 31 patients so far, and these patients have been followed anywhere from 2 to 32 months. And all of these patients, after receiving gene therapy, all these 31 patients after receiving gene therapy have been free of sickle cell disease complications. So on the right-hand side, each line here is an individual patient. And you can see that the patients who were infused in the very beginning on the top, they have been followed very long. So how long the line is how long they've been followed. So this patient has been followed for about 32 months. and this patient for 23 months, and so on. So there have been a lot of patients who have been followed for a very long time. Some patients have been followed shorter, and they have about 40% fetal hemoglobin. So if you have 40% fetal hemoglobin, your cells don't sickle, and these patients don't have any complications from sickle cell disease. Now, this company has filed for FDA approval of this drug, and it is expected to cost around 2 to 3 million dollars. And we'll talk about the price point in a little bit, but I want to share all the results with you first. There is another company which was developing another gene therapy using a similar approach. Instead of using Cas9 as the scissor, they were using a different scissor called zinc finger nucleases. They had treated 4 patients, out of which 3 patients were free of sickle cell disease symptoms. They had about 30 to 40% induction of fetal hemoglobin, except for 1 patient in whom the fetal hemoglobin was just 12%. Unfortunately, this company closed the trial and they are not developing this product anymore. Um, what we've been told is that it was a business decision, and perhaps they didn't think that their product is going to be successful enough, and so they stopped the production. So this trial has stopped and they are not recruiting any more patients. And it is unlikely that this particular way of doing gene therapy will ever get FDA approval. So this sort of thing happens a lot in the field where trials get stopped because the companies decide that they are not going to be very successful. Um, Using the second approach where we were using shRNA, there has been a trial being conducted out of Boston Children's Hospital on which 10 patients have been treated and they have been followed for about 2 to 50 months. Of these 10 patients, 1 patient restarted disease modifying therapy, 1 patient remains on chronic blood transfusions after receiving gene therapy, and 4 other patients have continued to have some sickle cell disease related symptoms. In these patients, the fetal hemoglobin has been anywhere from 21 to 42%, which is a little bit lower from the fetal hemoglobin that we saw in the first study. And probably that's why these 6 patients out of 10 have continued to have some symptoms. But in all these patients, the symptoms have decreased from before. So it's not the same level of symptoms that they've had before, it's less. And they are conducting a multi-center study. So more patients will be treated on this trial at a number of different centers to see if this is a successful therapy or not. So that trial is still ongoing, and hopefully we'll learn more about that in the next coming few years. And then using the third approach, where we edited the BC, not the BCL11A gene, but the globin gene. There is another company called Editas Medicine, which is conducting this trial called Ruby trial. And so they are using another different modification of the Cas scissor. They are using a Cas12 enzyme, which is another molecular scissor, and they edit at the globin promoter where BCL11A goes and binds. So they have dosed 4 patients so far. They recently presented the data from this study at European Hematology Conference. And at least in the first 2 patients, the fetal hemoglobin has been around 38 to 44%, which is very close to the very first trial that we discussed. And all of these patients have been vaso-occlusive crisis free. So that's very promising news for this trial. And of course, as you would imagine, this trial is still ongoing. There was another trial being conducted by Novartis, which was also editing at the HBG promoter. They had treated 2 patients that had been followed for a period of 6 to 12 months. They had 25% fetal hemoglobin, but unfortunately that study closed because, again, as you can imagine, 25% is not as much as what the other trials were showing. And so they didn't think that perhaps they would be as successful as the other trials. So like I said, these sort of things happen a lot for non-medical reasons in pharmaceutical world. And so uh, before I start talking about these trials together, you would be thinking that, I mentioned that if this is a spelling mistake, what CRISPR-Cas9 does is this. It basically causes a spelling mistake. And I just noticed here the spelling of CRISPR over here is wrong as well. That's not intentional. I apologize. But CRISPR-Cas9 nevertheless causes one spelling mistake and it changes that into something else. You would say, like, why can't we do this? Why can't we actually go and fix something? Why can't we fix a spelling mistake? So this can be done now. There are advanced base editors which are even a newer modification of the CRISPR-Cas9 enzyme, and these base editors do exactly that. They basically go and erase the wrong spelling and they fix it and they make it the right spelling. And there is a trial being conducted by yet another company called Beam Therapeutics. It's called the Beacon trial, which does base editing at the HBG promoters. No data on this trial has been posted so far, so we don't know anything else about this except that they are using base editors. So hopefully in the next few years we will learn more about how this new technique of base editing is doing, but we don't know much about it yet. um, and that, of course, if we could do that, we would then be able to go and do gene correction, where we don't have to knock out a gene, we don't have to go fix a gene. We would just go and fix the spelling of the sickle mutation, and that would take care of the problem. So the big question, people would ask me is, which one of these therapies should I pick? And there are so many different things you told me about. My head is spinning. They're so complicated. I don't understand. Just tell me which is the best and which one should I pick. Um, so the unsatisfactory answer here is we don't know which one of these therapies is the best one. We at least we don't know yet. If you would notice, very few patients have been treated in all of these trials. On one trial, 30 patients; on another trial, 4 patients; on another trial, 2 patients. That's a very, very small number. And these patients have been followed for a very short duration of time. If you saw, the longest was 32 months, that's less than 3 years. So we don't know a lot of things about these trials yet. What would happen if more patients got treated? What would happen when these patients got followed for 5 years, 10 years, 15 years? We don't know all that stuff yet. At least what we know is that the initial signal on these trials is promising. And we hope that how these patients have been doing in the first 6 months, 10 months, 20 months, that they keep doing the same way for the rest of their life. But we don't know that yet. So if you ask me today, which one of these therapies should I pick? My answer would be, we just don't have enough data to answer that question yet. Um, and like I said, these short-term results are promising, but we need long-term safety and efficacy data. We need to see data over 5 years, 10 years. And so that's why it's important to follow these patients very long. And so we'll keep an eye on that, and hopefully next year or in 2 years I can come and tell you a little bit more about these. And then maybe I can answer that question, which one of these therapies should I pick? So, if you are considering gene therapy, I would strongly encourage you to participate in one of these clinical trials. It might help you, it might not. Um, so far, most of the patients who have gotten treatment on these clinical trials have done well. Their symptoms of sickle cell disease have gotten better. But as you notice, not everybody got better. There were some patients who had less fetal hemoglobin induction and they were not doing as well. So it is possible that some of these treatments may not work for you. It may work a little bit, may not work completely. All that is possible. And so I think everybody needs to understand that these are very, very new therapies and we don't know everything about them. And we hope that they work, but they may not work for everyone. But if you participate in a clinical trial, at least it helps advance these therapies. It helps us gain that much knowledge about these therapies, and it helps us make treatments better for the next person who's going to get them. It helps us make the treatment better for patients who are going to come and get these therapies next year or in 5 years or in 10 years. Literally, we have made all this progress in the field because we have been doing clinical trials. So I strongly encourage you, if you are thinking about gene therapy, sign up for a clinical trial. But before that, talk to your family, talk to your doctor, see if that is a right option for you. Gene therapy is not going to be right for everybody. There are a lot of individual things that need to be considered. There are lot of known risks. There are a lot of unknown risks, as we have talked about in previous classes. So gene therapy may or may not be right for you. So talk to your doctor, talk to your family, see if it is the right thing for you, and if you can, sign up for a clinical trial. I also want to talk about this concept of a cure. You know, when we talk about these therapies, and I don't like to call them curative therapies for a reason, because we don't know what exactly a cure means. So I'll give you a few examples. A cure could mean different things to different people. Some people would say, if I don't have any sickle cell disease associated pain events, that's a cure. Another person who's on chronic transfusions does not have pain events as much. They will say, well, if I don't need to get blood transfusions, that's a cure for me. We also need to talk about other problems that sickle cell disease causes. So I tell all the patients when I take care of them that their body is like a wall and sickle cell disease is like a hammer. Sickle cell disease hammer keeps chipping on their wall every single day, and it causes problems on their organs. It can cause heart problems, kidney problems, lung problems. It can cause stroke. It can cause bone death. All these problems can happen because of sickle cell disease. And some of these things are irreversible. For example, stroke. Once stroke has happened, there is nothing you can do to fix that. You cannot gonna uh, go back to being completely normal again. We also think that if liver injury, heart damage, kidney injury happens because of sickle cell disease, we may not be able to fix that. Future generations. So, if you get transplant or gene therapy, it only fixes sickle cell disease for you. It does nothing for your children. You can still have children after undergoing gene therapy or transplant, and they can get sickle cell disease. So it only helps you, it does not go on to the future generations. So, once again, when we talk of the concept of cure, I think it's a very loaded word and it's a little complicated. And so, my suggestion to everybody is everyone sort of needs to define what cure could mean to them. What would it mean to them? And then talk to your doctor and see, hey, if I did this therapy, would I get that? If you've had a stroke, it will not fix that. If you've had bone death, it may not fix that. It will not be passed on to your future generations. And that may be okay for some people. That may not be okay to all. For some people, a cure might mean that their number of pain events that they're having may go down, and that may not be enough for somebody else. So I think what a cure means for a person needs to be individualized. So I like to call them transformative therapies, because believe it or not, everybody, their life will be transformed if you undergo these treatments, hopefully for good. Even if it is not a cure, at least it will change their life a lot. It will hopefully improve their life a lot, but that may not always be the case. So these are transformative therapies as far as I'm concerned. They're potentially curative, but may not be curative for all, and not everyone might achieve a cure. And so, like I said, they are all transformative, hopefully in a good way, but could be in some bad ways too. So, where do we go from here? At least two of these genetic therapies, one by Bluebird Bio, which we talked about last week, and the other one being made by Vertex, hopefully will be commercially available by the end of this year. And both of these therapies, from what the expectation is, will cost between $2 to $3 million. That's just the cost of treatment, the cost of blood transfusions, getting treatment in a hospital, all that will be extra. So we don't know yet if and how insurance companies will cover for this, how many patients will be covered, in which states it will be covered. This is all a big question mark. Um, I, I I personally think that expecting an individual to pay for these things on their own is just almost impossible. But remains to be seen, at least at this price point, how these therapies will be accessible. I worry about that. As far as a clinical trial is concerned, on the clinical trial, the sponsor of the clinical trial, which would be one of these companies, would be covering the entire cost of treatment. So if you're participating in a clinical trial, you would not have to pay for anything at all. Um, so that's something to know. But the good thing about these therapies is that, unlike transplantation, where patients need to receive immunosuppressive therapy after transplant, after getting gene therapy, you don't need to get any immunosuppressive therapy because there is no risk of graft versus host disease. But at the same time, long term safety data from these treatments is very much needed. So we will keep an eye on that. And hopefully, in the next few years, I'll come back and I'll talk to you more about these therapies. So I will stop there today. And I'll be happy to take any questions right now. If I'm not able to answer some of those questions today, please feel free to email me at akshay.sharma@stjude.org. That's my email address. I'll be happy to answer any general questions there. And like I've told you before, I also tweet about sickle cell disease and transplantation and gene therapies. My Twitter handle is Akshay Sharma MD. So if you want to follow me, please do, and we can continue the conversation on Twitter. So with this, I will stop. I will leave the screen on for a little bit so that you can note down my email address or my Twitter handle. But Alexis, if you have any questions coming up from the audience, or if you have any questions, we can take them now. Alexis, you might be muted. I can't hear you.
Miss Alexis, you are muted.
I know I am, right? Okay, you can hear me now, right?
Yes, I can hear you. Great.
Okay. So I was saying that I like the way that you used analogies and everything to describe what happens within the cell, so that it's not just, how you sometimes you may speak with doctors and things like that, and it's just like you're reading a textbook. So I like that for sure.
Thank
I
you.
don't see any questions in the chat, but Sharonda, do you see any questions on Zoom?
So I will say that, I think the ending of this presentation is very unsatisfactory. I think people were probably hoping that I will give them an answer, uh, that this is the better one, do this. But that's the problem with new therapies. Gene editing has been around only for the last 5-6 years. So it's a very, very new treatment. And it's a great question. Can you have gene editing at any age? Theoretically, yes. But I can tell you that because these are very, very new therapies, when gene editing began, we only would start doing gene editing in adults first. So the first few patients, or first several patients actually, who got gene editing were all adults. They were over 18 years of age. And these trials have an upper age limit. So some trials stop at 35, some trials stop at 40, some stop at even 30. And so these trials initially began at that 18 to sort of 35 years of age. And then once several adults had gotten gene therapy and they were doing better, then they started reducing the age, and then a few teenagers got it. And to my knowledge, the youngest patients have been around 7 or 8 years of age. So to my knowledge, nobody has been younger than that. But again, like I said, this field is evolving very rapidly, and I don't know if somebody younger than that has gotten a transplant. So that can happen. But anyway, there is there is an age limit, and there is an upper age limit, and there is a lower age limit for these gene therapy clinical trials. And I expect that when they become commercially available, FDA will ask that that age limit be maintained.
Okay. I have a question. So in 2021 I got a solid organ transplant. I got a liver transplant, like the complete full thing. So that process, along with like hospitalizations, medications, all that stuff, plus post-op treatment and everything, um would basically like organ transplants, especially solid organ transplants, be considered in the same category somewhat as like a special type of surgery procedure and whatnot?
Yeah, so bone marrow transplantation is a little bit different from solid organ transplantation in the sense that you don't have to undergo a surgical procedure per se. As I mentioned earlier in that cartoon where I showed, you have a patient and we collect their stem cells. Those stem cells are collected by a process called apheresis, where you are connected to a machine which looks like a exchange transfusion machine for those
Yeah.
of you who have undergone an exchange transfusion. So we collect stem cells by doing that, and then you get those edited stem cells back by a very similar process by getting a blood transfusion, essentially. So there is no surgery involved in getting a bone marrow transplant. So there is not going to be, you're not going to go to the OR and nobody's going to cut open your belly, and all those things don't happen. But just like you said, when you get a solid organ transplant, you get immunosuppressive medications. If you underwent a transplant, you would get immunosuppressive medications, but
Mm-hmm.
after gene therapy, you don't need immunosuppressive medications. And so those
Okay.
are some differences between transplant and gene therapy.
Okay. Thank you.
Sure.
Does anybody else have any questions or concerns, maybe?
I would like to hear and see if
Let's
people,
see.
what do they think about gene therapy? And it's so new. I have been doing it, and I haven't done a whole bunch. I've only been doing it for like 4 or 5 years. Um, how would you feel about it? Would you be willing to do something which people have only been doing for 4 or 5 years, which only, let's say, 50 people in the entire world have received? How do you think about that?
So I've
Um,
considered it. I've considered it quite seriously. And at the moment, I am in the process of looking for a donor for a bone marrow transplant. But if the option was made available to me to be transplanted with myself, I'd
mhm.
actually take it, because I'm to the point though where I think it's a little bit different. And the reality for me is that I have come to the realization that even with a bone marrow transplant, I'm either going to live or I'm going to die. There are only two options here, and I'm going to do that anyway.
Yeah.
So for me, that's where I am now. I'm to that point where I'd go for it, but I can understand why so many others might not feel that way.
Right. Yeah. So to add to that point, Dr. Bailey, for bone marrow transplant, we've been doing it for more than 30 years, right?
Hmm.
Some sort of bone marrow transplant we've been doing for 30 years. So we know a lot about bone marrow transplantation in the sense that we know what's going to happen to you in 1 year, 2 year, 10 years, 20 years. And some people, even though it's an estimate, I cannot tell you what's going to happen to you, but I know what has happened to the thousand other patients who have gotten it, right?
Hmm.
And so for some people, there is that comfort in knowing what might happen. Gene therapy is sort of that black box that we don't know. We don't have the luxury of knowing what might happen to 100, 200, 500 patients in 10 years from now, right? So how do you, if I may ask you, how do you think about that? And you know, and I think that's what you were saying, that some people may not want that for that exact reason. So how do you think about that?
Well, I think that's a reason why a lot of people wouldn't want it.
Mhm.
And I understand that. I think that's perfectly reasonable and rational.
Yep.
Um, I will say that when hydroxyurea first came on the market, I was not remotely interested, and it was pushed on me several times to be part of the trial, and I did not want to. Um, and I take hydrea now, but it took it being on the market for a good decade before I considered it.
Yeah.
And so I totally get that. I think now it might be age. It's because sickle cell is progressive and where I am now and how bad it's gotten, that it's a balance. And for me, I'm going to live or die anyway. And so might as well do it in the pursuit of life. That's where I am. But
Mhm.
I do get that that's sort of an extreme mindset that, well, the only two choices are life or death, so let's go for it. That's a very extreme mindset.
Yeah.
There's no shades of gray.
Yeah.
And so I get that. Like I understand that not everyone is there. And I can understand why there will be many people who will choose to wait.
Right. No, that's an excellent point, and thank you for sharing that. I certainly hope, and I'm sure everybody does too, that you live a very long and fruitful life, because the community needs you, we need you. But at the same time, what you said, it seems like your thoughts have also evolved over time. As you mentioned, for hydroxyurea, you thought about it a certain way in the beginning, and then as more data emerged and you
Exactly.
knew about its safety, you changed your mind. And now you are in a different mindset with respect to your disease. So for every patient, where they are with respect to their disease, how severe their disease is, they may want to consider all these risks for themselves in relation to where they are. And I think that's very important. And that's a decision that I can't make for them, you can't make for them. They have to make that decision for themselves. And the only way they can do that is by educating themselves, by learning about these therapies, by knowing as much as possible, and then talking to as many people as possible.
Yeah. And we have a
Okay.
few questions.
I was gonna say that. Yeah.
And I'm going to ask that they start popping them on the screen. If there, go ahead, Alexis.
So our first question is, how safe is the delivery mechanism of the CRISPR-Cas9?
Yeah, so as of now, it is very safe. So CRISPR-Cas9 is delivered into the cells outside your body. So as I mentioned, we take your stem cells, which make all the sort of blood cells, we take them out in a laboratory, we add Cas9 to those cells, and Cas9 protein is very short-lived. Within a couple of days, it's gone. So it goes into the cells, it does what it's supposed to do. Those scissors, they go and cut where they're supposed to cut, and then the protein disappears. So by the time these cells are being put back into your body, the Cas9, CRISPR-Cas9 is no longer there. But the effect that it has caused on the stem cells will stay forever, because once a change has been made to your stem cells, that change is permanent. And so while there is not a lot of risk from CRISPR-Cas9 itself, the effect that CRISPR-Cas9 has on your cells can have long-term effects. And so one of the things, again, it's an extreme example, has not happened yet, but one of the things to think about it, we think and we hope that these scissors are very, very precise and they go and cut only where we want them to cut. But what if they go and randomly cut somewhere else?
Wrong
And they
place.
cut somewhere important, somewhere that it's absolutely supposed to be normal, you know?
Mhm.
And that sort of abnormal cutting could cause a problem. And that's why I am saying, all of us, while we are similar in certain ways, we are also very different. So we all have a beta globin gene, we all have a gamma globin gene. These things are normal, right? But at the same time, we all have a lot of genetic diversity, which basically means that some of our DNA looks different from each other. And so those 30 patients which have been treated, or 50 patients or 100 patients, they may have looked very similar to each other and they would have the same sort of cutting when Cas9 was used. But there may be that 101st patient or 200th patient whose
Where
DNA
it cuts.
looks just enough different that this scissor makes a mistake and cuts somewhere else critical. Now, we hope that doesn't happen, but that's the risk which we just don't know, um, you know, how and when that'll happen. Um, Related to that, Dr. Bailey, you just put a question in there in the chat between Cas9 and Cas12a. Um, Cas proteins are all very similar, and same thing as zinc finger nuclease, which I mentioned briefly. There was a company which was doing that. These are all scissors which go and cut at a certain place. Now, these all scissors, the way they cut is very similar, but they can all make mistakes. And so, in some aspects, they are similar. In some aspects, they are different. Uh, but honestly, there are not too many big differences as far as patients are concerned about how they are done.
Mhm. Thank you.
So the whole process looks very similar on how this is done.
Okay.
Okay. Um, are we able to compare gene therapy outcomes that have been performed in other disease states, looking at long-term outcomes for this foreign territory? That's a great question.
Yes.
As far as I know, gene editing has not been performed in any other disease so far. All the other diseases, at least the blood disorders that we are talking about, they have undergone gene therapy using a lentiviral vector, which we talked about last week. And so, yes, to some extent, we can. But then I should also say that all lentiviral vectors are made differently. And on at least one trial, using a lentiviral vector, which is different from the lentiviral vector which is used for sickle cell disease. On that other trial, for a disease called adrenoleukodystrophy, in that particular disease, a number of patients developed leukemia,
Mhm.
and some of those patients developed leukemia because the lentiviral vector integrated in the wrong place. The
Mhm.
lentiviral vector went and joined the DNA near a gene which causes cancer. And unfortunately, that caused that cancer gene to get activated, and those patients develop leukemia. Now, we know that two patients on a sickle cell trial also developed leukemia, but in those two patients, lentiviral vector didn't have anything to do with it. So every lentiviral vector is different, and it's hard to compare the knowledge that we gain from one trial for another trial. And there is no other trial that I know of in any other disease other than thalassemia and sickle cell disease that is using gene editing as of now. There have been gene editing trials for high blood cholesterol, where gene editing therapy is being delivered to the liver, but that's completely different.
Okay. Another question is, how do we create more awareness about CRISPR, considering there's a lot of controversy about the technology?
I wouldn't say that there is controversy regarding the technology. I would say there is lack of education about the technology. And that's true for any new technology. When something comes out very, very new, um, people don't know much about that. And partly that's because the technology is new and we don't have any follow up on that. And partly because it's complicated. That's why I tried to explain CRISPR-Cas9 and how it works in many different ways. Sometimes by showing you genes, sometimes by showing you spelling mistakes, because one way may not be good for everybody. Like I said, when I first learned about how it works on genes, I didn't understand it either. I needed somebody to show me the spelling mistakes, and that's how I understood it. But now I've been dealing with it for last 5 6 years. Now I know what it does. And if you are hearing it for the first time, you may not get how it works on the genes either. you know it has taken me 5 years. It'll probably take you at least a few months, if not longer, to understand. So I think the it's lack of education, lack of information, and that's why uh, forums such as this, these sort of classes where we talk about it, where we can freely exchange information. Um, and by when I say freely exchange information, hopefully you find this information coming from me as somebody you can trust. Of course, there are educational materials being produced by a lot of different people, and some of those people um, have reasons why they're spreading that information, and sometimes that reason may not always be a good reason. They may have other benefits that they might get out of it. Not always. I'm not saying everybody spreads education because they're getting some benefit out of it. Um, and how the quality of that information may or may not be good or bad. Um, Dr. Bailey and I have known each other for many years now. I think it's been over 4 or 5 years, Dr. Bailey,
I think so.
and Dr. Bailey and I, we have worked on these things together. And so I trust Dr. Bailey and Dr. Bailey trusts me. And so, and that's why Dr. Bailey is willing to put that stamp on what I say. That's why behind my back here, I can put the logo of Sickle Cell Consortium and the Warrior University, because Dr. Bailey trusts what I say. And hopefully you trust what I say too. But of course, if I am saying something and that's not true, I would be welcome to receiving feedback if you would like to receive that information another way. So I think forums such as this, where information is being delivered by somebody who's trustworthy, by somebody who can authoritatively speak about these things. Like, I have done this thing, so I can speak about it. I can tell you, like, I've done these therapies. I've been a principal investigator of some of these clinical trials. I know what happens on those clinical trials, so I can give you that information adequately and appropriately. Um, and I don't get anything out of this, right? I mean, the main thing that I get out of this is if even one patient learns something and it benefits them, that's all I want to know. Because as a sickle cell disease doctor, as a hematologist, my ultimate conflict of interest is that I want all of my patients to do better. And if this is how I can help them, that's a win for me. And so I hope that these sort of forums can help patients learn about these therapies, and hopefully we can get rid of some of that misinformation out there.
I think it's important, and I'm very grateful that you were willing to come and teach all of these three series together so that we can have this collective unit of information. Because there's the only way that we're going to. I really genuinely believe in order to have informed consent, you must first be informed, and this is the first step to that. And I agree with Dr. Scott. Great presentation, Dr. Sharma.
Thank you so much. It's
Yes.
You guys are so kind.
Do we have any other questions, either on the Facebook or the Facebook? I sound old. Either on Facebook or here.
Because I know my grandfather says, "Oh, you're on the Facebook, right?"
I think that's it, Dr. Sharma. And we came right to 8. So I guess we're also out of time. But thank you so much for this information. It has been incredibly enlightening. And everyone, these videos are going to be in the Warrior Network. And so they will be uploaded at Sickle Cell. Wait. Oh my, scwarriornetwork.org. There it is. I got there. scwarriornetwork.org. You can go ahead and sign up. It's free. And eventually, not eventually, but very, very soon, you'll be able to watch this entire series. Next Thursday, I will be coming back with you just to summarize some of what you heard. I won't be going in as much depth. I won't be reviewing those matters again, but just to summarize and to let you know where we're going with this next. So please, if you've missed any of it and you'd like to see the entire series, go to scwarriornetwork.org. There it is on the screen. Thank you so much, Dr. Sharma. Thank you
Thank
so
you
much,
so much.
Alexis, and
Thank
thank you
you.
to all who have joined us. Tiara, I've just answered that question. Yes, these videos will be available afterward at scwarriornetwork.org. Yes, ma'am, you're very welcome. Thank you all for joining us. And do remember that you can go and catch up on this and all the other classes. There's probably at least 100 videos at this point. Well, that might be an exaggeration, but maybe there's at least 60 videos at this point educating on all different topics. Catch up on this series and on everything else in scwarriornetwork.org. We have someone from Facebook. Thank you so much, Dr. Sharma. I'm based in the UK and have really enjoyed these presentations. Thank you. And thank you all for joining us. And we will see you at the Warriors Convention. The next parts of this, after next Thursday, we will have additional conversations at convention. They are going to cover topics such as what support is available for caregivers, managing patient expectations, and what are your rights and responsibilities when undergoing curative therapies, as well as discussions just on this in the community setting. So if you are interested in being there virtually or in person, you can register at Sickle. Let me make sure, sicklecellconvention.org. Thank you all again. Thank you, Dr. Sharma, and we will see you all next Thursday.